Okay, so let's talk about GBS or Guillain-Barré syndrome. I want you guys to be sure to keep this one separate in your mind from some of the others. It'll seem a little bit similar, but it's actually quite a bit different. So you'll see that it's flagged up there at the top as not part of the central nervous. This is peripheral nervous system. Etiology unknown. Incidence 6 in 1 million. And I actually know somebody. She wasn't one of my clients. She's actually our daughter's principal. She was a former science teacher, so she knows, she knows her stuff a little bit. And I mean, she's principal of an elementary school. You would never know that she had any kind of condition like this. And I most certainly wouldn't have known. She just somehow we got on the topic, and I was like, I'm the only one that knew even what it was about. So that kind of gives you a little picture of that this is not necessarily a debilitating, deathly disease. Okay, so what it is it's an acute inflammatory disorder in which the body's own immune system attacks part of the peripheral nervous system. So the immune system comes in and attacks the myelin sheath that surrounds the axons of the peripheral nerves. We've talked about the myelin sheath before with MS and different things, but we know that that damages the ability to transmit those signals to the muscles like it should. Now, the big difference here is under the clinical picture. They start to recover generally 2 to 4 weeks after the initial onset. So they contract Guillain-Barré, and usually they go downhill, okay, like severely. Maybe they're in the hospital, maybe even on a ventilator, but they're gonna have some major sickness and major changes, and they're gonna start recovering. The medical management here looks like IVIG, which is intravenous immunoglobulin therapy. And what that's about is that they go in IV and they inject proteins that help support the immune system to naturally to help your body fight off those organisms that way. Okay. And so I had a fancy table for you guys, and then I was like, you know what, I think this does more harm than good. But we'll come back to the role of OT where it says it progresses as the client progresses, but I want to move on to the next slide to kind of give you guys a little bit more of what I'm talking about. So 85% of these patients will recover well spontaneously. So after that 2 to 4 weeks of getting the disease, then they start to recover, okay? And then 20 to 30% of those who recover will have maybe some residual deficits, such as some distal numbness or weakness. And then 10% may have significant impairments. 5% can die from complications. Okay, so still serious, but if they can make it through that period of sickness, then they tend to just trend back upward. Okay, and so that's really neat, and that's the encouraging part of Guillain-Barré. So here what you guys would want to think about is back where I said the role of OT, right? So it's going to progress as the client progresses. And so after they've been hospitalized and they had that duration of really severe sickness and illness, then they're going to start recovering, and they're going to need maybe some resistance training, some training to be able to get back to their ADLs and their prior level of function. Let's pause while my husband drives by. Okay, so that's a little bit about Guillain-Barré. All right, let's move on to myasthenia gravis, and this is one that I wasn't so familiar with from school. That doesn't mean that they didn't teach it to me. That just means that it didn't stick for whatever reason. And then I remember getting out and seeing it a little bit more in clinical practice. Okay, so this isn't going to be a lot on it, but if you guys do happen to run upon it, you'll have a little bit of a background knowledge, and then you can go dig up more about it to learn a bit more in detail. Okay, so it's an autoimmune attack on the acetylcholine receptors, and it's a progressive disabling process. Incidence is 14 in 100,000, and it tends to affect younger women and older men. And then the medical management there. So cholinesterase inhibitors, corticosteroids, immunosuppressants, plasmapheresis. Okay. And this myasthenia gravis, it's often undiagnosed because it is very rare. And then it just has vague symptoms too. So some of the things that these folks may have trouble with would be muscle weakness in those cranial nerve innervated muscles. So it could look like dysfunction in their eyes. Maybe they have ptosis, which is like the drooping, the diplopia with the double vision. Maybe it's the dysarthria in their speech, dysphagia, proximal limb weakness, things like this, okay? And then also a thing to know about this is that symptoms can fluctuate over the course of the day. So maybe at one point of the day, they are just really downhill. And then maybe another part of the day, they're trending back up. They're not so bad. And so that's pretty complicated too. While these folks may be having a relapse, they may suffer even so much as having like quadripresis symptoms, okay, to where they're just not even able to move. So that's a little bit more about that. Like I said, get more information about myasthenia gravis, run into it. You need to know a little bit more, but that kind of gives you a little bit of a background, okay? Okay, moving on to Alzheimer's disease. Not going to stay here for a long time because we have talked about it in geriatrics recently and then also previously. Make sure that you read your text. Make sure that you are familiar with the stages. But do know that it's a degenerative condition in the central nervous system. We're pausing again for my husband and dog to ride by. And then dementia is the umbrella term, right? So it's the overarching term for vascular dementia, Lewy body dementia, frontotemporal dementia, and then Alzheimer's, which is the most common. That's why it gets the most talked about. But it's important to remember that they are not one and the same. All right, so again, I was telling you guys to reference back to those stages of dementia, kind of look for some of the hallmarks of each stage to kind of ground yourselves, but then also know that, that with Alzheimer's, so as OTs, and specifically, like if you get kind of bogged down on maybe a test question, think about just broadly, what do you know about Alzheimer's, right? So if they're in the beginning stages, we know that it's going to progress. So we need to plan for that progression. We can do education of the client and the caregiver. We can start to do compensatory strategies. And so just think about it overarching, okay? And then also start to think about in the more severe stages when they have lost so much of that cognitive function. Think about the things that you would do, right? So safety would be a concern. We've got to still have them be able to eat. We've got to do a lot of caregiver education again about teaching them the strategies to best work with that individual. But we always know that we're going to try to keep them as independent and as involved as possible. So I hope that makes some sense. I don't want you guys to get bogged down so much in the specific, what specific stage is this, as much as I do the whole general aspect of treating Alzheimer's and the various stages of dementia, okay? All right, now on to multiple sclerosis. We watched the video, Marsha, I want to say her name was Marsha, and you guys kind of saw some of the problems, some of the more unique problems that she had around her home, and reference that if you need to, but you kind of were able to see how she looks like that she's functioning, but she has some things here and some things there, and multiple sclerosis is one of those things that's going to look different on different individuals, okay? So it's one of those where it's going to say it depends. Some folks that you may have family members or people in your community who have multiple sclerosis and you may never know. Others may be debilitated by it at times. And so that's one of the tricky parts with MS, okay? From the video that you guys watched on Marsha, some of the things that I noticed on her was that she almost had a flat hand, so the atrophy of the muscles in her hand. It was demonstrated both along the thenar and the hypothenar eminences. I noticed that she had unsteady gait, and you guys picked up on that as well. We talked about this. She had fatigue. She was also a pretty good OT for herself, right? She had made a lot of modifications, but then there were some that were still yet to be made, right? So we talked about other solutions that maybe she could have used that she didn't yet. If we were in class right now, we would be talking about this, and I would want to hear from you all more. Some of you saw how she used the channel lock pliers to open things. I would like for her to have some energy conservation techniques, even more so, with her ADLs and her IADLs. Even having a place to sit, to dress, and shower, I think would be beneficial for her. And then when we watched the video of her cutting the vegetables on the cutting board, I know that made you guys nervous, and it made me nervous, right, too. But the cutting board, if you noticed, had a little indentation on it, and she was trying to cut carrots or celery or something that was kind of round. And I was like, man, why doesn't she just slide that right up into that little indentation and use that to hold it, and kind of help that stabilize a little bit? So I was curious if any of you guys thought that too. But so that kind of gives you an idea of some of the clinical presentation of MS, and just that it's gonna look different for different folks. Okay. So it's a slowly progressive diagnosis of the CNS. So we talked about that ALS is quickly progressive. This is slow. It is the most common in young people, and it's characterized by the patches of demyelinization in the nerves, okay? Signs and symptoms can appear and disappear, so they can have exacerbations and remissions. And I feel like that is best demonstrated in one of the other pictures. So this is kind of how it looks with a normal nerve fiber. I've showed you guys this picture before, and you've probably seen it in other classes as well. But there you see where it started to demyelinate. And so the level of demyelinization can affect the severity of their condition, right? So we're going to talk about the relapsing remitting, which is the majority, and then also there's secondary progressive relapsing, and I think it's all summed up really nicely here in this picture. He doesn't just drive up and down the driveway usually, I promise. He's taking off the trash back and forth. So finishing up here on MS, this picture. So the first one there at the top shows the benign multiple sclerosis. So it shows where they're stable. They might have a little relapse, but then they're stable again. So you're not going to have any trend in either direction necessarily. So those you probably wouldn't know so much. You're not, no. Okay, we're going to take a break. Be back soon, hopefully. Cheers, you guys. We're doing so good. So good. Okay, so probably should have taken a minute to orient you all to this graph, but hopefully you figured out that the vertical axis, is that your y-axis? Frankie would want me to know this. I think that's your y-axis. And the other one is your x-axis, okay? And so the x-axis is the time, and then your y-axis there, your vertical one, is the disability, okay? So that first one, that's where we're saying it's going to go on, and it's going to be pretty well stable for the duration. The second one is the relapsing remitting. So it's stable, then they have a relapse where they have a pretty severe period and they're not feeling well and they're just not doing great. And then they go stable again, but they're not at the same point. They may have some residual deficits, okay? They're not coming right back down to their prior level of function, okay? So that's what's important to remember here. So they'll relapse a little bit, and then they still may have some deficits, and they'll relapse again. They'll lose a little bit more. Okay. And so that's what, that's kind of how I choose to think of MS is, maybe they're fine, and then maybe they have some vision disturbances, and some sensory loss when they're in their relapse. Maybe they have bladder control loss. Maybe they have vision loss and sensory loss during this relapse. And then maybe once they stabilize again, maybe most of it comes back, but maybe they still have some vision disturbances, okay, that are staying through that. So that is important to think about. Hi, sweetheart. And then the secondary chronic progressive, you can see that is similar until it takes off in that upward trend there, okay? And then the primary progressive, which it says is 10 to 20% there, is a pretty steady progression. So they're not going to really have the remission stages, okay? And then the other thing to think about is that in that little graph on the second one there, it looks